word about Dr. Klein is that Drew, I know him very well for the past about 3 years, and I've followed very closely his publications in the area of coronary and peripheral intervention. Drew is an extremely prolific publisher, writer, author of articles in the sphere of peripheral and coronary interventions, and he has really dedicated his efforts to mobilizing support for the Journal of Society of Coronary Angiography and Interventions and also for the society itself. And his work as a key member of the planning committee of the SCI National Conference has really taken him to the national forum. So it's a great pleasure to have him today at the Xlpad Forum, and I invite him to present his talk on common femoral artery interventions. Take it away, Drew, and I urge each one of you, if you could please mute your lines.
Great. Thanks so much, Subhash. I appreciate it. And, I actually would love to come back to Colorado, Aaron, so anytime. But this is where that's where I trained, and this is where I first started learning the skills and some of the techniques I'm going to show you guys here today, which is on the endovascular management of common femoral disease and a study in shifting paradigms. When I was training, common femoral disease was off limits, thought to be only a surgical disease. However, hopefully I present some cases here today and some data that shows perhaps this can be managed endovascularly. I have no financial disclosures. I am, however, an internist and a cardiologist and a vascular and endovascular specialist. And like Chris White always says, I believe open arteries are better than closed arteries. Outline for the day today, just this brief webinar, we're going to talk about data review, and next question is what data? There's not a lot of data out there. And I got 3 cases that I entitled, as you can see there, and including a 4th hot off the press case that I just did about half a week ago that we just put some slides in for. So hopefully these 4 cases will show you some common femoral approaches and some tips and tricks, as well as highlight some mistakes that I did, and hopefully you don't make these same mistakes. Really, the largest series that we have out there for common femoral endovascular approach comes from Bonvini and the German group, which essentially looked at a total of 355 interventions to the common femoral, mainly with balloon angioplasty. There was a fair number, 36.9% with stent. This was done a few years back, prior to more of the prolific, more of the expansion of atherectomy devices. There were 25 that underwent Silverhawk atherectomy device, some using kissing balloons or so-called special techniques. I think what I've going to show you is some of the data for both balloon angioplasty, and really what we need here is a randomized controlled trial to show what would be the best way to approach this, but I'll show you my approach to it here in St. Louis. Really, when you look at the multivariate analysis of what predicts failure, complications, restenosis, and need for TLR, if you break it down, essentially you have a higher risk of failing the procedure endovascularly at the common femoral if it's a bifurcation lesion. They had a higher rate of failure if they didn't need to place a stent. Of course, that's going to be confounded. And more recent procedures, so-called recent greater than 2001, meaning with experience in the common femoral, you can become better and better at what you do, and also bolder and bolder in the cases that you take on. Higher complication rates occur when there's a chronic total occlusion, which is not surprising, as well as if you're diabetic. In terms of restenosis, in this large series of, again, 360-plus patients, if stents were not used, you had a higher rate of restenosis. Again, this was mainly balloon angioplasty alone. If there was a bifurcation lesion present, if it's more than a Medina 100 lesion present, i.e. a complex lesion, you have a higher chance of restenosis too. Again, not surprising, very similar to what we see in the coronary system. And as coronary interventionalists, I think all of us know that when you're tackling an LAD diagonal lesion, 111 or 101, that it's obviously more complex. You got a higher rate of restenosis than if you're dealing with a straight-up LAD lesion. And so same thing here in the common femoral. If you're involving the ostium and the SFA and the ostium profunda, it's obviously much more challenging to deal with, and there are various techniques and tips and tricks you can use, but the restenosis rates are higher. Along with that, the need for target lesion revascularization. If you look at this data, shows that if you have infrainguinal disease plus your common femoral, it's obviously worse. You really should be treating outflow and inflow at the same time. Again, kind of predictions of bifurcation lesions, more complex lesions than if stents weren't used. Very similar to what on the rates of restenosis as well. if you look at the subgroup analysis, and since we're going to be talking about atherectomy today, if you look at just the 25 patients, again, very, very small series. You can't compare that to PTA plus stent because obviously you see the numbers there, 25 versus 335. However, if you look at your 1 year target lesion revascularization, it's relatively low, about 4.8%. Complications were 0. Failures were 4, with a restenosis rate about 11%. So again, not bad for that small number. Again, this was in kind of the earlier years of atherectomy. So take it for what it is. It's data. It's not much, but actually more data coming out around kind of the same time from some surgeons looked at 98 patients treated with balloon angioplasty alone. Some got stents. About 40% of critical limb ischemia patients got stents. 24% of the claudicants got stents. And what predicted outcomes were the sicker patients, obviously. Rutherford 5 and 6, so ulcerations predicted worse outcomes. So did diabetes. And obviously, like surgical data, if you need outflow of the SFA popliteal. So if they, in this study, if again relatively small number, if the outflow was compromised, the restenosis rates and failure rates of endovascular intervention to the common femoral were much, much higher. There's a classification scheme put out by this group. I don't find this very helpful. I prefer the Medina classification, but this is one potential classification scheme one might see, and I bring it up for types 1A through 1D. I think this is more of a classic surgical classification versus the Medina classification, which I think most of us are more familiar with. Again, 100 being the most simple and easiest lesion to tackle. The French published their experience of 25 patients, again 70% for claudication, only 30% for critical limb ischemia. They planted a fair number of stents, 43 stents, and a mean follow-up of 22 months. One of the concerns that all of us have in placing stents against the common femoral is stent fracture. They noted only 1. They had a restenosis of only just 1, 20%, and their patients did pretty well with clinical improvements, both primary and secondary, of 80 and 90%, and target lesion revascularization 85%. So it is interesting that they did the secondary clinical improvement status, meaning they've had to go back in and re-intervene. It's small data. It's one group, but it's interesting to say nonetheless. Actually, I think the nicest data actually comes from Aaron, your group out there. Prior to your arrival, I think Phil Datillo, Ivan Casserly, Tom Tsai published this in CCI in 2013, looking at what predicts outcome. They had a series of 30 patients that underwent intervention, some for atherosclerotic lesions and some for access-related reasons or relations, which I'm going to show you cases of examples of both those today. And what we know in atherosclerotic lesions is that these patients have more calcium. They do have a great acute success. However, they have a worse long-term outcome. Versus access-related lesions or related complications of the common femoral that are managed endovascularly do very well acutely and also do very well long-term, likely because what we're dealing with here is that the diffuseness of the disease is not as great in these patients. And usually it's quote-unquote a normal vessels, and what you're dealing with is a dissection mediated by the vascular closure device of the common femoral. If you look at data from Bonvini, again looking at predictors of adverse events, it's again claudicants with the higher worst disease, 3 and 4. I would have put that in rest pain, as well as diabetes. I think we touched on this earlier. And if you look at Phil Datillo's very nice summary of all the data here, from these references on the left are basically all the publications that are out there from 2004 to 2011, obviously not including their own series. And if you look at the number of patients you're dealing with here, they're extremely, extremely small. So 20 to 30 patients, largest one being Bonvini at 321 or 360 procedures. Technical success rates, however, are extremely high, 93 to 100%. So most of the time what we see here is that endovascular management is indeed technically very, very successful with a relatively low complication rate. If you look at these numbers, 0 at high of 5% in that one series from 2011. The clinical improvements show that most people do very, very well. The issue here is whether or not they will do long-term, sort of what we're seeing in the SFA as well. The acute phase, if you can get through, is I think people do extremely well, but what's the long-term outcome? And right now, we don't really have the data. We have no RCT data on what the best way to treat these lesions are. There's a lot of anecdotal data and a lot of case series is all you're seeing here. And what we really, really need, and Subhash, this might be a nice CSP trial down the road here, or Aaron, maybe all of us can get together and perhaps do this, would be actually provide some real data for this field because it's wide open. So the key points is, and as we're launching into more, going into what some cases that I'm going to highlight here, is that really, if this is your first venture into the common femoral land, you got to pick the right patient. A 100 lesion is by far the best. A non-CTO, non-diabetic with claudication. Vascular closure device mediated lesions are easier to treat than athero. The key thing about common femoral disease is you need true lumen status. You do not want to go subintimal in the common femoral and compromise flow to the profunda. That is the sacred vessel of the leg. Don't mess with it, just like in the abdomen you wouldn't mess with the pancreas. And really you want to achieve the maximal luminal diameter possible. We do use IVUS if needed within the common femoral to make certain that you're getting the maximal luminal diameter you can. The key thing also, just like in the surgery, inflow and outflow must be fixed. So if you have a problem with inflow, that needs to be fixed. You have a problem with the SFA popliteal, also should be fixed. I believe long and low inflations of balloon angioplasty work very well. Again, this is kind of borrowed from our earliest years, prior to my time, thankfully, of coronary interventions when 3-minute, 5-minute prolonged inflations, you can get away with this. Patients are tolerating it very, very well, in contrast to the coronaries, and obviously following these patients not only with ABIs but with duplex, and if need be a re-intervention, if need be, can be a lot easier to treat when the lesion is at 50% versus when it's at 100%. So with that, I'm going to launch into some cases. If anybody has any questions, I'll stop here and just show you kind of how we have progressed here in St. Louis. Any questions on the data, what little limited data there is? Probably not, since you guys probably all are very familiar with it. This is a case I call entitled Force of Hand. This was actually my first common femoral case. I came here to St. Louis in August of 2009. This was a case that I was looked at in September of 2009, and it was a non-diabetic claudicant with Rutherford class 3. He had 3-vessel runoff. He had a very focal lesion at his common femoral. He also had an SFA distal lesion, as you can see here on the right-hand side. I referred this patient to surgery based on the common femoral lesion and my experience that I thought that an endarterectomy here, followed with a fem pop bypass, would provide this patient the best long-term outcome. Secondary to the marked calcification you can see here of the vessel, both in the common femoral as well as distally. However, he was turned down for surgery for a variety of reasons, and now presented with rest pain and small dorsal foot ulcers. 9 months later, he was in considerable pain, and no one wanted to operate on him. So at this point, we took him back to the lab as a endo kind of bailout. And this is what we dealt with. And now everything is closed. The common femoral is completely shut down, and the distal vessel was also shut down. If you look at the baseline here at this now 2010, this is where I wish I had gone back in time and just fixed it then. Now the SFA was completely occluded from top to bottom with very, very limited runoff. For crossing this, once we had a 7-French sheath in crossover position using the internal iliac as an anchor, we essentially then crossed this with a stiff angle glide wire and a Quickcross, and then this actually went through relatively easily, and then used a 014 wire system to selectively get into the SFA. What you can see here is injection through the Quickcross of dilute contrast, showing that there was a patent area of the SFA here. I won't show you the downstream lesion, which we also fixed at the same time, and focus this more on the common femoral today. We then proceeded with TurboHawk directional atherectomy. I prefer this for the common femoral because I like the ability to control where the blade is cutting. Again, the main lesion was down here, if you remember, here in the common femoral, highly calcific lesion. Used a large vessel standard tip calcium cutter. This was after one atherectomy pass, and this was after the second. And after atherectomy alone, this is our common femoral result here. At the end of just atherectomy alone, we proceeded balloon angioplasty, low pressure, for 5 minutes actually, 6x60 balloon. Probably was a little undersized, and that was our final result. This patient did very, very well. We went on to fix his downstream vessel, which actually turned out to be much more of a beast. We used a Pioneer downstream, wound up having to atherectomize and balloon angioplasty down below, but overall he did very, very well. His patency at 6 months and 12 months was still 100% here in the common femoral. He did have some restenosis downstream, but this actually was a great result in my first venue into the common femoral, and I thought that this started giving me a little bit of confidence that perhaps we could treat this endovascularly. The next case I'd like to show you guys would be a case I call Double Down. This is something that kind of talk about how to learn from one's experience, and this was a 70-year-old gentleman with a history of diabetes, so he already has a risk factor for restenosis of common femoral. Coronary disease, he's had CABG and presents with left lower extremity claudication. On my exam in the office, he had an absent left common femoral palsy. He had actually failed 3 months of Pletol and refused surgery. His ABIs are there. He has an ABI on the left of 0.47 and a toe pressure of 50. This preemptively, I like to try to get a common CTA if I can, if the creatinine will avail it, so I can have some sort of planning strategy. This showed that indeed we're dealing with a calcific lesion here in the common femoral. He's also got calcium down here in the left SFA at the adductor hiatus. And also very, very important is how you're going to get in. It looked like the right side we were going to get in without a problem. I didn't show it, but the crossover looked relatively benign as well, so no high or highly angulated bifurcations. This is our angiography that we obtained here, and what you can see here in pelvic angiography at 30 degrees contralateral. As you can see, very high number of collaterals and a complete occlusion of his common femoral. This is our baseline looking at the left here. You can actually see kind of we have complete occlusion of the SFA all the way down, but it's impossible to see how much blood flow is actually coming through because of the occlusion proximally. We actually did get some recon down here at the popliteal post the adductor hiatus. For this, I really wanted to work on focusing on trying to stay true lumen for this, and therefore I took a Pilot 014 wire, Pilot 200 with a Quickcross, and for this we'd use a Pilot, we use a Quickcross 035, 135 just to make certain that we can switch up to a 35 wire if need be, or I might try a V18. Interestingly enough, this first portion of the channel was very, very easy to get through with the Pilot, and showing indeed that we were true lumen. From there was a distal cap that with one kind of push of the Quickcross with this stiff angle Glidewire kind of popped right on through. Again, confirming that we were indeed true lumen. At this point, we wanted to proceed with a stepwise progression, and this is kind of my approach. First of all, I wanted to confirm that indeed we were in the true lumen. Injection showed the SFA actually was open here. Performed a pre-dilatation with a 3.0 balloon. I often use this for atherectomy. The crossing profile of a turbohawk device about 2.7. One could use here Jetstream or CSI without having to do this, but I thought a low pressure inflation here would be beneficial, so we can get an idea of exactly where the lesion is, where most of the plaque was, and that's my bias. When you then see this post low pressure balloon angioplasty, you can see most of the plaque is actually lateral. It's very calcific plaque. It's right at the ostium of the profunda, and this is going to make this a very challenging lesion to cross. We then wired the profunda with an 014 wire. Confirm that with I use a Quickcross 035, and actually through the Quickcross I actually put a spider filter down the profunda and a spider down the SFA. Of note, if you're going to do this, you do need to have an 8 French system in place, and that's what we had done. I learned this from a case actually I'm going to show you next. But an 8 French system, you can put double wires down, one to the profunda, one down the SFA. This allows you to feel a little bit safer about atherectomy. Again, you can't use with the Jetstream device, you cannot use the EV3 wires. It will get stuck. I've had it several times get stuck on the wire, so you're going to need to use no protection or a I'm blanking on the EPD that you can use with that, but it's one of the carotid filters. And the issues here is that we really want to be protective of the profunda more than anything else. So we performed atherectomy on the profunda wire. Again, this is, and the reason I chose this is that you can see that most of the lesion is going in, is lateral at this point. Essentially directed the blade and the cutting blade towards the lateral aspect of the vessel. The mistake I made here was I actually didn't go back and I didn't atherectomize the common femoral in the medial aspect. I should have done that, and I'll show you why. When we went up with a balloon angioplasty at low pressure with a 7mm balloon, there's a small retrograde dissection here by not cutting the SFA wire immediately. I think what you can see here is that you have two wires. You can clearly see which wire is going where. You have to do this on 8-inch. The key here being, of course, that blade will cut through that other wire if you get too close to it. So very delicate sort of work in here, and you want to make certain that your wires are clearly separated. This becomes an issue if you're going to bring back your device, and if the wires start getting wrapped up, you have to make certain that you can clearly see that there's a separation between the wires before you want to activate the device. At follow-up, this was what it showed up at the end of the case. This is our final angiography of runoff. His duplex was very well superficial, had a little bit high duplex in zone 1, which is probably this disease in here. Otherwise, he looks very, very good. His common femoral duplex is 127, 241. That was for more kind of into the profunda. He actually is doing very well clinically. His ABIs are normal. He's had complete resolution, and this is, again, at 6 months follow-up at this time. So we're continuing to follow him up every 6 months with the duplex and see how he does with an ABI at the same time, and if need be, go back in. But overall, he is very, very happy with his same day, go home that day treatment. Just a point of advice why I always use EPD. This is actually the embolic protection devices, the spider filters from that case. You can see that there is a fair amount of debris in both the profunda and the SFA, as well as other debris that we took out. But this is exactly why I think if you're going to do atherectomy, it's important to have distal embolic protection. Maybe not so much with the jet stream, but with the jet stream you can use a NAV6 filter. But at the same respect, I think if you're going to use directional atherectomy in a turbohawk device, I think it's very important to have this downstream because of this entity of distal embolic protection. You don't want to be chasing this down for the remainder of the case. The last case I'm going to show you, or second last case, is a case I entitled Fool Me Once. It's a 62-year-old gentleman who underwent left heart cath at one of our referring VAs on January 4th of last year. His access was the right side. He had coronary disease. It was medically managed. He had an angioseal to the right groin. And he actually called the office 2 days later saying that he had right leg pain. This was down, again, to our referring hospital. Said no bleeding, but he just kind of starts feeling bad. I get the call like Maxwell Smart, and this is the physical exam that I, of course, didn't get told about, but when I went back and looked at the chart, and I was reading very closely, then the patient went in, he said the findings on the exam distinctly different from my exam, the operator's exam just 2 days prior. Our referring physician was called, that was me, and a cath lab was arranged for a week later. Now, that was a mistake. If you get a phone call in any sort of that sounds anything like this, I think the best thing to do is not just get the patient up ASAP, and we'll show you why. So that was a symptom problem that I had, or a mistake that I learned from. And this was the initial angiogram. We got a cine film of it, and essentially shows common femoral axis. It may be tough to see. It may be I couldn't see initially whether or not this was right through the SFA through the profunda, but on the lateral oblique view, you can see that it's distal common femoral. This operator chose to angioseal this. Curious on the audience, would you guys angioseal this? Anybody have any problems with this? Relatively smooth common femoral. Aaron, would you angioseal this out of curiosity?
I try to avoid using angioseal in most cases due to one or two experiences like this, and so I perclose everything now.
Yeah, you know where this is going. And so I now realize we're at Colorado while we were at Perclose Lab, and this is a good example of it. This is 1 week later. This is essentially the pelvic angiogram. You can see he's got relatively normal vessels, actually, which is a nice predictor of that he should do well overall. Obviously, the problem is here, the right common femoral. And this is an indication of what we're dealing with here. If this is thrombus, dissection, it's a disaster is all it is. We actually were able to cross with a V18 with a Quickcross, so an 018 wire with a 035. And this is actually a case I did before the first. So mistake I made, the second mistake I made was I only put a 7 French crossover sheath in, and I got entry into the profunda. We navigated into the superficial femoral, confirmed that. So now I got wires in both of them, and basically did that low pressure balloon angioplasty like we saw before. And this, I have no other word but ugly for this, and it just looks uglier all the way down. And so if you go all the way down, his actually runoff looks very, very good. It's got 2 vessel runoff to the foot, with the DP being dominant. So it's relatively mild, if any, disease down through the distal infrainguinal vasculature. And a great quote that I was taught was, good judgment comes from experience, and experience comes from bad judgment. So my third mistake was to have to pull the profunda EPD to TurboHawk, because I thought, that's what I'd done before. Let's see if it works. There's no real change. And then my next thought was, this must all be thrombus. We then used a DVX angiojet on thrombectomy mode, which is just the aspiration mode as well. And this is when the proverbial BS hit the fan. And now you can see that the profunda is completely out with thrombus. This doesn't look much different. You can see that this is probably all thrombus, and by waiting a week, this was just made this that much worse. We then basically got a cross back into the profunda. I then tried to essentially do what I could, try to get this device out, or try to get this thrombus out. I actually even tried to lasso it with the embolic protection device, couldn't get any of it. We wound up having to do pulse spray thrombolysis. Again, for those of you who are not familiar with pulse spray thrombolysis, this is used with the angiojet catheters. Essentially what you do is pass this over a 014 wire. You can mixing your cocktail that's going to spray the clot with TPA. If you're inside a VA system, you may want to talk to your pharmacy beforehand. It took us, the first time we tried this, 45 minutes to get this from the pharmacy. We essentially spray the clot with TPA, wait 20 to 45 minutes. It's the most painful 45 minutes or 20 minutes of your life, letting the clot kind of take effect, and then go back through there and use the aspiration mode to try to essentially break up the clot. For the profunda, just to let you know what we did here, at this point, so in case you ever get stuck in it, we essentially aspirated, thrombectomized, and then there was clot still residual down, so we wound up having to do was essentially pass wire 014 wires down, do low pressure balloon angioplasty as well with a 210 nanocross, and essentially push the clot out to the side. We also did low pressure balloon angioplasty up here, and obviously had the patient on heparin, and eventually went up on Coumadin. So we restored flow to the profunda, which was critical. Then went on to deal with the rest of the vessels. This is that 5x2 power cross sitting here in the profunda, not where I generally like to balloon angioplasty, but I think at this point you don't have much of a choice. So this was after the balloon angioplasty, the profunda, feeling a little bit better with more flow down the PFA. Again, the common femoral actually looking a little bit better as well after TPA. We also did drip a little bit of 4 to 6 milligrams of TPA directly into the profunda as well. And then went on to deal with the common femoral, since we're focusing more on that today. You can see here we're using an 8 millimeter. This is a huge common femoral. Used an 8 millimeter balloon under roadmap because I didn't believe that a common femoral could be that large, but indeed it was. We actually then I went back and dealt with, I wanted to go back and deal with what appeared to be the dissection flap. Now that I could get to it beyond the thrombus, I went back with an atherectomy device and cut out actually the dissection flap from the angioceal-mediated device. Then I used a 9 millimeter balloon. This, again, is the largest common femoral I've seen to date. And essentially just did low pressure balloon inflation for approximately 5 minutes. And this is our final result. After about 4 hours and a fair amount of sweat coming off my brow, we were able to restore flow through both. The profunda is back. All vessels are now open. SFA was open. Downstream, we did collect a fair amount of debris in the spider, obviously. Unfortunately, from there, the patient has done very, very well. This is our distal final. We have no, I didn't show you the foot, but there's essentially, here we are here, runoff all the way to the foot, no change. And this patient actually did very, very well long term. Again, kind of final angioplasty or final angiography of the common femoral. So it was Miller time, just like the Ghostbuster said. We actually gave him Coumadin for 3 months. His duplex was normal at 3, 6, and 12 months, and he's continuing to do no symptoms. I'm just going to show you one last case, a very abbreviated case, because I think this would show you a different atherectomy device as well. It's hot off the press. This was a PACE, and I apologize that these are not as pretty pictures because I was just making them. But this is a case of a guy with critical limb ischemia. Our surgeons had stented him from his common iliac on the left-hand side all the way down to the tip of his common femoral. He then has a gap, and then again stented his SFA from the ostium all the way down. Everything was out on CT angiogram. We actually crossed this relatively easily. Wound up having to use a Simmons 2 to get our crossover device in, and wound up using a Balkan. But once we were able to cross this, get on down through the true lumen, we then used a jet stream device here throughout this to basically get rid of the thrombus, as well as some of the organized thrombus, as well as any additional plaque. This was after balloon angioplasty, and I thought for having not used a lot of it in the iliacs, this looked phenomenal. We then went through, this was the jet stream all the way down. I basically used the jet stream device all the way down through the entire common femoral into the SFA, all the way down. And just since we're focusing more on the common femoral, this is what it looked like after jet stream device in the common femoral. I actually thought that this wasn't good enough. I went back and hawked this, and this is what the device looks, this is what the common femoral looked like after that. We did low pressure balloon angioplasty. Patient was saying with his finger right here, yep, that's exactly where to go, doc. And then just to kind of talk about preservation and inflow, when we got this crossover there was a residual dissection right at the common iliac that we had to deal with from the crossover side. So it's very important to make certain that your inflow is fixed as well. Overall, this patient did very, very well, and we basically restored flow all the way down. We also used the atherectomy device, the jet stream, all the way down through the SFA within the stents, had no problems with that. There were about 3 or 4 focal lesions, which I did not show further down within the SFA, that were resistant to the jet stream device. That allowed directional atherectomy to be obtained, and since I had the device out anyways, I went down and cut those out well. The balloon angioplasty basically restored flow. The guy had complete resolution of his symptoms and is doing very, very well. And with that, I'm going to thank Subhash and Atif and Karen and Jabraful, my resident here, as well as our veterans for their patience and for taking care of us, as well as the opportunity to take care of them. Thanks so much. Subhash?
Thanks a lot, Dr. Klein. Dr. Banerjee, I think he's
probably went into the into the lab if I know him.
Yeah.
I'll take any questions with that all.
Yes,
thanks for joining.
This is Lake Shamas here. I don't know if you can hear me okay.
Yeah, I can hear you perfect.
Great cases, by the way. These are excellent cases. Just to share a little bit of my own experience. I pretty much start to use the jet stream on all these cases, and I find it extremely helpful if your vessel size is about 6 millimeter or less. As you know, with the blades up and the XC cutter,
yep.
You can get about 3.4 millimeter, cleaning perimeter. You don't get more than that.
Yep.
And in fact, we did look at the wobbling effect. We have some animal data that we're going to be presenting soon, and it doesn't really do a whole lot beyond that perimeter.
Okay.
Bottom line is if you have a big vessel over 7 and higher millimeter, you don't get a whole lot. And I agree with you. The TurboHawk, seems to be an excellent device in that situation. You can direct it anywhere you want and pick up all the tissue that you want out. We find out that the filters are almost essentials, with these, especially if you have, and I do use the NAV6 on pretty much all of these. One of the things that I see in the case that you had with the collagen, because we see those, pretty frequently. Not that it's not a good thing. Let's put it that way.
Not a good thing. Yeah, we just had one ourselves.
Yeah, but I've tried. It's interesting that I've tried the off-label use of the jet stream on those, and the use of a NAV6 filter is, has been merciful in that situation.
Yep.
Using always the destination sheath, with the hemostatic valve that you can remove because, as you know, you can fill those filters very quickly, and there's really no way you can retrieve them out unless you have a sheath with a hemostatic valve, that you can unhook and take the filter right straight from that sheath. And to me, that sounds like always the sheath to use, when you use these filters in these kind of cases. Go ahead.
No, I was going to say that it's nice to hear that you agree that the wobbling effect, it's so funny to hear the reps. Oh, you get a 5 millimeter cut. You don't get a 5 millimeter cut. You get 3.4, and that's what you get.
No, yeah, absolutely. That was the theory. I mean, you can see that in certain vessels which are large, you get that major wobbling of the device, and you think you're cutting a lot more. We did a lot of porcine data, and again, it's going to be presented at CRT coming up soon here. But again, we don't see a whole lot, of wobbling impact, but again, it is important to keep in mind the vessel size determines the effectiveness of the jet stream. If it's too large of a vessel size, you're not going to take a whole lot of tissue, and you're going to be left with a lot of residual narrowing. I find it super effective between 5 and 6 millimeter vessel sizes.
Gotcha. Yeah, obviously the cases I showed you, obviously I have never seen a common femoral 9 millimeters, but
that was huge.
I mean, this guy's a pretty big guy, but it seems out of the ordinary. But it's at the same respect, I think it's a good thing to have all the tools on your shelf. I prefer I have both the Jetstream. I actually have CSI and the TurboHawk. I prefer the directional aspect and I didn't show any cases, but sometimes I've even brought that down into the Profunda. I prefer using the Jetstream and the Profunda if I have to, because it just makes me feel a little bit better about
yes.
I don't
Drew, can you hear me?
Yeah.
I want to ask you a question. I'm sorry, I was having a hard time connecting. I'm actually
no problem.
But no worries. My question to you is that I know you have good experience. These are outstanding cases. Do you offer a common femoral treatment, endovascular, after your surgeons turn you down? I'm asking for a general broader audience. And if you could please define how do you strategize these cases, or you decide, you do the diagnostic first, have a joint conference, and then go in, and what are the things you do to actually perform this?
So part of it is if the surgeons have turned patients down, like that last case I showed you, the surgeons have turned that patient down. I will generally, as a rule, try to get a surgical opinion. I have one good working relationship with one of our surgeons, and try to get there is very challenging. And so I think, we are trying to establish here at the VA a joint conference to kind of go over these cases. My particular approach, some patients are referred to me if they have, if I have a CT angiogram showing disease, if it's just focal disease, especially if it's a 100 classification, I feel comfortable tackling that front line without consulting a surgeon. However, if it's very complex, especially 111, or an area where they have that they're clearly going to need a more long-term durable approach. I also take into factor the patient's comorbidities. As you know, our veterans are very sick, and so many of them have had issues with surgery, and the last common femoral. And it's last case bias, right? The last had a massive wound infection requiring a wound vac and everything else. So common femoral endarterectomy as a rule in very experienced hands is a great outcome. It can be done under local, actually, in some centers. So it really just depends upon kind of what's the inflow, what's the outflow, what's the overall patient. Is it calcific disease, is it not? And so it's a really patient-to-patient perspective.
Fantastic. Any additional question, Erin? Do you have any, and anyone else?
This was a great conference.
No, I think those are some amazing cases, Drew. This conference will be available online, and your slides will be shared. If you could, if there are any questions that we get in writing, we will pass it along to you.
Sounds great.
I greatly appreciate you taking the time. I know you had a busy clinic this morning, and taking the time to present at this forum, and I think it will make for an excellent publication.
Yep, that's. I know, Aaron, we were talking about this as well, and Subhash, we'll talk offline and go from there.
Thank you very much.
Thanks so much, guys.
For joining in.
Appreciate it.
Happy Thanksgiving to all. Thanks, everyone.
Thanks. Happy holidays.
Bye-bye.
Bye-bye.